Right, beta. So lovely. Good evening to all the lovely doctors of this country. And now, what I feel is, if we can do a revision of whatever we have discussed in adult surgical problems, I think. Let me just take the opinion of all the great doctors uh, for revising the way we revise pediatric surgery, the same way we would revise. Welcome, welcome. Thank you, Puneet. Yeah. Sir, if the question comes like squamous columnar junction move upward, what we choose, Barrett's or sliding hiatus hernia? Yes, so that would be a real tricky one because in both the cases, the squamous columnar junction is going to move upwards. Okay, beta. However, however, sliding would be a better answer, as Aditya has rightly pointed out that in Barrett's, it is not that the junction is moving upwards, it is actually the columnar metaplasia of the lower esophagus. So if we have to choose amongst the best and there is no other leading point in the question, then we prefer sliding. Right. Okay. Right, beta. Okay, what we'll do is, first of all, let us discuss if you have got any questions whatsoever in your mind related to whatever topics we have done till now, and then we'll just do the revision of the adult surgery, first with the workbook and then without the workbook with the eyes closed, right? Okay. Any area beta which is causing you any trouble till now? Okay. 32-year dysphagia, regurgitation, chest pain that is relieved by drinking cold water, raising the arms. No history of reflux. Esophageal manometry demonstrate normal peristalsis with incomplete relaxation. Most likely diagnosis. So this is failure to relax. Dysphagia, regurgitation, options, diffuse, nutcracker, GRD. GRD is gone, beta. It is incomplete sphincter relaxation. So we have to just focus on ecclesia cardia. There is no specific pressure given as such. And let me just see if it is a diffuse story in the question. Dysphagia, regurgitation, chest pain, relieved by drinking cold water. No history of reflux, manometry, normal peristalsis with incomplete lower esophageal sphincter relaxation. Okay. Where is, yeah, normal peristalsis. Now this, wow. So congratulations, beta, to everyone. Basically, here there are two important keywords what we need to focus on. One is normal peristalsis, another is incomplete relaxation. So on the first instance, if we take a look, the answer goes in favor of ecclesia cardia. However, the only thing which is against ecclesia cardia is normal peristalsis. In cases of basically GRD, I hope we all can rule out, because in GRD there would be abnormal relaxation of the lower esophageal sphincter which is causing all this reflux, and here it is incomplete relaxation. So that means lower esophageal sphincter is contracted. So that means it goes in favor of ecclesia cardia. The only thing which is going against ecclesia is normal peristalsis. Now, in ecclesia, generally we see there is absence of esophageal peristalsis, or if not absence, it is reduced. If we have to differentiate from nutcracker and diffuse, in nutcracker we find hypercontractions. That means high amplitude contractions. And in diffuse also we find uncoordinated contractions. So if I have to choose amongst the given options, I would go with ecclesia cardia. Right. क्या बात है. Wonderful. Great. शगुन के साथ 901. Very good. Wonderful बेटा. Yes, Sanan. I have already requested the team that please do not delete the revisions which I am taking, and these revisions I want to continue to be with you till the day of exam. Whatever revisions we'll be doing, we'll request the team to keep them till the exam. See, the pain is relieved by cold water basically, yeah. Why relieved by cold water? It's not that it is actually relieved, but what happens whenever the food is getting stuck, and if along with the food water is also going, then that food and water together will put more weight. If it would have been just water, less weight, no relaxation. Only solid food, relaxation, story settles. But if the solid food is also getting stuck, then now when solid as well as liquid both are going towards the lower esophagus, so they will add more weight, and that liquid will help in moving that solid food downwards. I hope, Aditya, it is absolutely clear. Yeah, because Shweta, in adult surgery, if we revise the entire adult surgery together, it will take 3 to 4 hours without workbook, and then 3 to 4 hours with workbook. Nutcracker. For this question, the answer given is B. This is what you are trying to say. No, beta, I do not agree with this. How to choose the right investigation test for pain in right hypochondrium for adults? Generally, beta, first investigation what we are doing in right hypochondrial stories, it is ultrasound. And based on the ultrasound finding, we are going further. Generally, CCT definitely would be a better investigation if we have to look for the liver. But if we have to look for the gallbladder, then ultrasound would be a better investigation. And why it is so? Liver has got parenchyma, gallbladder has got bile which is fluid. Wherever there is fluid, ultrasound would be better. Okay. Okay, so what we can do is we can make a table here where there is ecclesia. If we are getting some space. I'm just trying to add one page after this dysphagia story so that we can clear this doubt, because this question is available on some platforms. So I think that is why it is creating a little bit of turbulence. The page is not getting added. Okay, so what we'll do is we'll just try to add it here. Suppose this is ecclesia, this is diffuse esophageal spasm, and this is nutcracker. Right. So basically, if we try to focus on what is the main pathogenesis in this, main pathogenesis, this is LES failed to relax, and here there are uncoordinated esophageal contractions, and here there are coordinated high amplitude contractions, usually more than 180 millimeter of mercury. Now, basically, if we see the onset, this is gradual, this is sudden, and this is intermittent. Then now where to write? Dysphagia. This is mainly for liquids. Then this is again for liquids, and here dysphagia is not absent, but it is not that prominent. And in the treatment, here basically we are doing POEM. Here we are giving CCBs nitrates. Here also we are giving CCBs and nitrates. Needless to specify beta that you find a bird beak. Here you find corkscrew. And here you may find slow clearance, not a classical corkscrew type of appearance. It may be normal as well. So you can just add a point here. What do you see on barium swallow? Here you can make a note that probably this is more than 120 millimeter of mercury. All these three, they are motility disorders basically. However, in achalasia, it is mainly failure of relaxation of the lower esophageal sphincter and esophageal peristalsis may be reduced or absent. The thing in that particular question which is taking your diagnosis away from achalasia is that is showing normal peristalsis. But the problem is in diffuse esophageal spasm, agreed, there will be peristalsis, but the movements will be uncoordinated and they will be, we cannot say that is normal peristalsis, but there will be more amplitude contractions, multi-peaked contractions will be there. So that line is also not justifying that esophageal peristalsis is absolutely normal, though there are ganglion cells which are present in the esophagus. So crudely we see that yes, the muscle movements will be there, but then those muscle movements will be high phased contractions. So that is uncoordinated contraction. In nutcracker, they are coordinated contractions, but of very high amplitude, multi-peak contractions, more than 180 millimeter of mercury. Right. Let's see if this suffices, or yeah, page is not getting added. Let me just try to understand. Acha, this was double bubble. Right. Bibek, that is intraesophageal pressure. Suman, that is intraesophageal pressure which is more than 300 to 400 millimeter of mercury, and here we are talking about multi-peaked contractions. Multi-peaked contractions more than 120 in diffuse, more than 180 in cases of nutcracker. Even intraesophageal pressure in nutcracker is more than 180. Okay, so there's another question. A 6-year-old child is brought with high fever with rigors for 5 days with pain in the right hypochondrium. 6-year-old, high fever, pain, fever, jaundice. No. Examination, patient is anicteric. So there is no jaundice, and tenderness is noted in the right upper quadrant. If there is no jaundice, then probably the biliary channel story is gone. So now we are focusing on pain in the right hypochondrium and fever, maybe liver story. What is the best investigation in this case? Okay. First investigation in this case will be ultrasound. There is nothing about jaundice, so we are not going with LFT and SGOT story. Now, whether to do a serology or contrast CT, because in the question is asking best. So best should be contrast CT. However, if this is a case of hydrated cyst in the liver, then we'll go with serology. But is there anything which is mentioned except for 6-year-old child, high grade fever, rigors, pain, no jaundice, tenderness is noted in the right upper quadrant. Now this can be a case of liver abscess. Ideally SGOT LFT should have been normal, but the best answer for this question should be contrast CT. However, this FMG solution might have given the answer as serology if they were thinking on the lines of hydrated cyst. First answer in this question would have been ultrasound. Right. So answer given is CT. Then it's fine. The only thing which was concerning for me was if FMG solutions would have given answer as B, then probably they might have been thinking about hydrated. Then they would have marked it at serology, because in hydrated we do ELISA to detect antibodies against hydrated antigen. If in the similar question there is some story related to hydrated, then you can mark serology as the best answer. But because in the question there was nothing mentioned related to hydrated, so thinking about liver abscess, we would have gone for CT scan. DS nutcracker pressure is still confusing. Okay, let me add this here. Just give me a moment. So basically these are multi-peaked contractions here. Where amplitude is measured. And okay, if we look at intraesophageal pressure, this is 25 to 100, this is more than 300 to 400, and this is more than 180 to 200. Now when we say multi-peaked contraction, then the game changes. Then here in multi-peaked contractions, it is more than 120 for diffuse, it is more than 180 for nutcracker. नटक्रैकर में देखो वो जो कह रहा है ना कि पेरिस्टाल्सिस इज नॉर्मल, व्हाई ही इज सेइंग पेरिस्टाल्सिस इज नॉर्मल इन डिफ्यूज esophageal spasm and nutcracker, because there is no absence of ganglion cells, so they are saying that yes, the peristalsis is normal. But basically what is happening in nutcracker and diffuse, if we look at this table, there are high contractions. That means there is peristalsis and the amplitude of contraction is more. So you can say it is hyperperistaltic. Difference between diffuse and nutcracker: in diffuse they are uncoordinated, nutcracker there are coordinated contractions. Right. Coordinated, beta, Amit, coordinated will give you the peaks at regular intervals, and uncoordinated will give you the peaks at irregular intervals. Right. Chale beta. So let's now quickly go into that, and let's now revise this adult surgical problem. First, we'll do the revision with the workbook. So in adult surgical problem, starting from top to bottom beta, first we talked about the Zenker's diverticulum. Zenker's diverticulum, this is a pharyngeal pouch or cricopharyngeal ecclesia. There is outpouching of posterior pharyngeal wall posteriorly above the cricopharyngeal sphincter through the Killian's dehiscence, that is inferior constrictor muscle fibers between the thyropharyngeus and the cricopharyngeus. Like, if we look here, suppose this is the starting point of esophagus. So here, if the tone of the cricopharyngeal sphincter is high, then pressure in the pharynx will be more, and this high pressure will force the posterior pharyngeal wall to protrude outwards. And this is going to cause acquired false Zenker's diverticula, or the pharyngeal pouch, or the pulsion diverticula. Why we are saying it is false? Because it does not contain all the layers, it contains only mucosa and superficial submucosa. Because all of us, we have got a weakness in the posterior pharyngeal wall in the form of this Killian's dehiscence or the Killian's triangle, that is between the thyropharyngeus and the cricopharyngeus muscle fibers. So this posterior pharyngeal wall protrude out through this area, and this may present sometimes as a swelling onto the left of the midline. Now, in 50% of patients of Zenker's, we find there are cervical webs also. What can happen in these patients? When the patient takes the rasgulla may go into the diverticula and may put pressure on the esophagus anteriorly, which can compress the esophagus, so that further eating will be difficult in this patient. Difficulty in swallowing will be dysphagia. That is the cardinal feature of Zenker's diverticulum. Because of this, there will be regurgitation, aspiration, and pulmonary complications. If the food remains in this diverticula for a longer period of time, there will be foul smelling breath, that is halitosis. Now, to examine these patients, if there is a swelling in the posterior part of the neck next to the midline onto the left side, if we try to reduce this swelling, it produces a characteristic gurgling sound. That is because of mixing of air and liquid. That is Boyer's sign. Bryce sign is seen in laryngocele. To diagnose these Zenkus diverticulum, we do a barium swallow and we can see a nice outpouching like this. And this is how we diagnose this Zenkus. In the treatment, if it is a small diverticula less than 2 centimeters in size, we do a cricopharyngeal myotomy. 2 to 4 centimeters, we do diverticulopexy. And more than 4 centimeter in size or big size diverticulars, we do a Dolman's operation, which is diverticuloesophagostomy, wherein we take a linear stapler, fire the linear stapler into the diverticula and the esophagus and divide the septum between the esophagus and the diverticula, so that the food will not be staying in the diverticula anymore and the food will be going into the esophagus, and there won't be any dysphagia, halitosis, regurgitation, aspiration, pulmonary complications. Another story here is about achalasia cardia. In achalasia, basically there is failure of relaxation of the lower esophageal sphincter, probably due to unopposed action of acetylcholine. Also, there are absence of ganglion cells in the Orbeck plexus, that is myenteric plexus in the esophagus. So the esophageal peristalsis is absent or reduced. Now, we can classify this achalasia into primary, secondary and pseudo. Primary, when there is no other associated disease or the cause is not known. Secondary, when it is secondary to other diseases like Chagas disease, diabetes, or maybe scleroderma. Pseudoachalasia is when there is no problem in the esophagus, but there is a problem around the esophagus and that is compressing the esophagus. For example, if there are tumors in the mediastinum, like big tumor in the mediastinum compressing the esophagus, or maybe tumors of the cardia of the stomach, they would be compressing the esophagus. When the pathology is not in the esophagus but outside the esophagus causing compression of the esophagus, that is pseudoachalasia. Generally, these achalasia patients present between 25 to 40 years of age. Most commonly, initially the patient presents with dysphagia, and this dysphagia is initially more for liquids and then gradually for both liquids and solids. Why not initially for solids? Because in achalasia cardia, the game is absence of relaxation of lower esophageal sphincter. So LES remains contracted. When the solid food is going down, because of its weight, the solid food can relax the lower esophageal sphincter and the solid food can go down. But if patient is taking liquid alone, then this liquid alone will not have that much of weight which can relax the lower esophageal sphincter, and that is why the liquid gets stuck. Obviously, if the food is getting stayed in the middle esophagus, the middle esophagus will get dilated, mega esophagus type of thing, and because of stasis, there will be chances of infection like esophagitis. There would be regurgitation, aspiration, pulmonary complications, halitosis type of features. If this irritation of the food persists for a long period of time in the middle esophagus, it can even lead to cancer, and squamous cell carcinoma can occur in the esophagus. How to approach a patient of dysphagia, because clinical examination is not going to be conclusive. So, we prefer doing some barium swallow. Now, when we are doing this barium swallow, we see this classical bird beak or pencil tip appearance. See how the tip is tapering, right? You can see this tapering. This is bird beak or pencil tip. This is the rat tail appearance, and there will be absence of gastric air bubble. Another hot image for the MCQs, you can see a bird beak or a pencil tip sign. This is the rat tail appearance, and this will be absence of gastric air bubble. Do not get confused with cancer esophagus. In cancer esophagus, we don't get that sharp bird beak or pencil tip. We may find a filling defect because the contrast is not going inside the cancer. So this is the filling defect area, and you can see the narrowing of the esophagus here. This is the rat tail appearance. So filling defect and rat tail appearance. We can also find a apple core appearance in cancer esophagus. Apple core can be seen in circumferential cancers and tubular structures. Most often apple core is seen in colon cancer. However, there can be different motility disorders, and if we have to segregate the different motility disorders, then we do a manometry, wherein we just put the manometer in the esophagus and try to record the intraesophageal pressure. Normal pressure in the esophagus is 10 to 25 millimeter of mercury, eclasia 25 to 100, nutcracker 180 to 200, and diffuse more than 300 to 400. In diffuse esophageal spasm, we find this corkscrew appearance, the classical corkscrew appearance. Now, in the treatment for eclasia, initially we can try giving calcium channel blockers and nitrates, but as we know, there is unopposed action of acetylcholine, so these medicines are not going to give us good results. We can try doing pneumatic balloon dilatation, which carries the risk of rupture also. However, this balloon dilatation will not be a permanent solution. There will be chances of recurrence. So a better option would be doing a myotomy. This myotomy can be done by open laparoscopic surgery, that is Heller's myotomy, where we just have to make an incision on the muscle layer. But whenever we are suspecting that we have damaged the lower esophageal sphincter more in myotomy, then the risk of gastroesophageal reflux disease will be high. And to prevent reflux, we do a floppy Nissen's 360-degree wrapping of the fundus of stomach around the lower esophagus, fundoplication. However, we can do this myotomy endoscopically nowadays very commonly, where no incision anywhere on the body. We just pass an endoscope into the esophagus, cut the mucosa, take the endoscope into the submucosa tunnel, and then incise the muscle fibers from inside. This is per oral endoscopic myotomy. However, we cannot do a fundoplication operation through endoscope. So generally we do POEM and don't do fundoplication. If after POEM patient develop more reflux, or if patient goes into GRD type of thing, then we have to consider doing fundoplication later on. Another story which can lead to dysphagia is Schatzki's ring, which is a circumferential mucosal submucosal thickening at the squamocolumnar junction, commonly seen in GRD patients. Because of GRD, there will be damage to the lower esophagus, inflammation of the mucosa, healing fibrosis can form mucosal submucosal thickening and a ring, and this can lead to intermittent dysphagia. Generally, patient does not have any problem, but if the patient is symptomatic, then we just do a single endoscopic balloon dilatation. We just dilate this through the balloon via endoscope. Lie stricture, this is basically a long stricture due to ingestion of castics or alkali. And definitely if the patient is having this type of stricture, then we have to resect the esophagus. We have to do esophageal reconstruction using jejunum, because this is a big procedure which has to be planned properly. So meanwhile, we can do a feeding jejunostomy in these patients, so that for that much period of time the patient is having the proper nutrition. Another story is about GRD. Now in GRD, we all know that refluxes from the stomach into the esophagus can occur in normal individuals also, but for 3 to 4% of times in 24 hours. That is not disease. When the frequency of these refluxes occur for more than 3 to 4% of times in 24 hours, then we start calling it as disease. Why we do not suffer from disease? Because there are three important factors which does not allow the frequency of refluxes to increase. One is the integrity of the lower esophageal sphincter, second is good gastric emptying, and third is good esophageal peristalsis. If somebody has to experience this reflux, these refluxes will be more commonly seen in a head-low position. If you have to compare standing, sitting and supine position, then in supine position, the refluxes will be more. Now, why this patient will develop GRD? That is because whenever the lower esophageal sphincter is damaged, then the chances of reflux from stomach into the esophagus will increase. And the most important thing which damages the lower esophageal sphincter is smoking. However, alcohol, chai, coffee, hot liquids, hot spicy food, obesity, progesterone, calcium channel blockers, nitrates, all can cause weakness of the lower esophageal sphincter. And if the lower esophageal sphincter has become weak, then the gastric acid will continuously reflux into the lower esophagus, giving that heartburn or retrostinal discomfort type of symptom. This is the cardinal symptom for GRD. There can be regurgitation, there can be epigastric pain. How we need to approach the patients of epigastric pain? First of all, we have to understand their lifestyle, because epigastric pain can be related to more acid. And we have to request these patients to avoid any kind of stress, stop smoking, alcohol, chai, coffee, hot liquids, spicy food, ask them to reduce weight, do not lie on the bed immediately after meals, at least for up to 3 to 4 hours, and elevate the head end of the bed by 5 to 8 inches. If this does not work, then the gold standard treatment for all acid related disorder are the PPIs. 90-95% of patients are successfully treated by PPIs. Why PPI can treat it? Because by giving PPI, the acid secretion will be blocked, so pH in the stomach will increase. If you are able to increase the pH in the stomach to maybe 5 or 6, then the normal pH in the esophagus is between 5 to 7. Whenever pH in the esophagus drops below 4, then we consider pathological. So by giving PPIs, if you increase the pH to 5, and even now the patient suffer from reflux, it is not going to cause any problem to the esophagus. So the symptoms are relieved. If patient is not getting relief by PPIs, then we need to do upper GI endoscopy to identify what is the cause for epigastric pain. And based on what we find on endoscopy, we proceed accordingly. So upper GI endoscopy becomes the investigation of choice for epigastric pain which is not resolving with PPIs. If you find a red hot lower esophagus, you suspect GRD. So you have to do a 24-hour ambulatory pH monitoring, because you have to demonstrate that frequency of refluxes is more than 3 to 4% of times in 24 hours. That is why you have to do a 24-hour study to diagnose GRD conclusively. When we are doing this ambulatory pH monitoring 24-hour, then if there is drop in pH below 4 for more than 4% of times in 24 hours, we label it as GRD. And that is why this is the gold standard investigation. This criteria is called as D-Meester criteria. So do not get confused if they ask what is the investigation of choice for GRD. It is upper GI endoscopy. But more commonly they ask what is the gold standard investigation for GRD. Then the answer is 24-hour ambulatory pH monitoring. Right. Now, if on endoscopy you find that esophagus is normal, but suppose you find an ulcer in the stomach, then stomach ulcers should be considered as malignant unless proven otherwise. So you have to take a biopsy from the ulcer to rule out cancer. Plus, because the commonest reason for peptic ulcer is the Helicobacter pylori, so you also have to take a biopsy from the pre-pyloric region to confirm this bacteria. If suppose esophagus is also normal, stomach is also normal on endoscopy, but patient is having epigastric pain, you take this endoscope in the duodenum. And if you find a ulcer in the duodenum, no need to take a biopsy from the duodenal ulcer because they hardly ever become malignant. But yes, you have to take a biopsy from the pre-pyloric region for this bacteria. Right. Once the diagnosis of GRD is made, medical treatment is not working, then the only option left is surgery, where we do a floppy nascence fundoplication. In floppy nascence fundoplication, we wrap the fundus of the stomach all around the lower esophagus. So this is 360-degree wrapping of the fundus around the lower esophagus. This is floppy nascence fundoplication, right? Floppy means a bit loose. It should not be too tight, otherwise it can cause dysphagia. There can be various complications of GRD. Most common is esophagitis, and most often this is in the lower esophagus. Whenever there will be esophagitis, there will be healing fibrosis. So stricture esophagus can occur, and these strictures can contract, which can lead to shortening of the esophagus. There can be Barrett's esophagus sometimes. There can be sliding hiatus hernia seen sometimes. In Barrett's esophagus, there is intestinal columnar metaplasia of the squamous mucosa of the lower esophagus, where the hallmark is goblet cells. Goblet cells are not present in the esophagus, but if on endoscopic biopsy you find goblet cells in the esophagus, it is diagnostic that it is Barrett's. Why there is intestinal columnar metaplasia? Because continuously if the acid is refluxing into the lower esophagus, it is damaging the squamous mucosa. So the lower esophageal squamous mucosa want to protect itself. So it prays to God that God, I also want that mucus barrier which the stomach is having so that I can also protect myself. And that mucus barrier is formed by the goblet cells in the columnar lining. Gastric columnar, intestinal columnar. Intestinal columnar have more goblet cells. So when the lower esophageal squamous mucosa wants that mucus barrier, God says, I will not give you gastric columnar, but I will give you intestinal columnar because there are more goblet cells there. So it is an intestinal columnar metaplasia. And obviously, because now there is columnar lining in the lower esophagus, so the squamo-columnar junction, which was earlier lower down, it has moved upwards. And there is very high risk of adenocarcinoma developing in this Barrett's. When we are doing endoscopy and we find severe dysplastic areas which carries a very high risk of cancer, then we should do endoscopic mucosal resection of the dysplastic area followed by radiofrequency ablation or argon ablation, and then give PPIs. Sliding hiatus hernia can be a complication of GRD. Along with sliding, we'll also discuss paraesophageal or rolling type of hiatus hernia, which sometimes can be called as giant hiatus hernia also, especially when huge amount of more than 50% of the stomach is going into the thorax, or not only stomach, maybe some other organs are going into the thorax, then we call it as giant hiatus hernia. Here we can see if this is the diaphragm. Normally we are seeing that gastroesophageal junction is within the abdomen and the entire stomach is also within the abdomen. Hiatus means the opening in the diaphragm. If the stomach goes into the thorax through this opening in the diaphragm, that is what is hiatus hernia. Now in GRD patients, because of reflux, this reflux can force the GE junction to move upwards. If this gastroesophageal junction moves upwards into the thorax, then we call it as sliding. But paraesophageal is a different story. In paraesophageal, there is weakness of the diaphragm here. So it is the fundus of the stomach which is going into the thorax. The GE junction remains within the abdomen. So to differentiate sliding and paraesophageal, we try to look for the location of GE junction. If the GE junction is in the thorax, it is sliding. But if only the fundus or maybe other portion of the stomach is in the thorax while GE junction is within the abdomen, then it is paraesophageal. Sliding hiatus hernia is much more common than paraesophageal. Uh, Reflux association is seen in sliding, not in paraesophageal. Chances of complications are more in paraesophageal, like ischemia, ischemic ulcers, and strangulation, perforation. Simple reason, if this is the blood vessel going up, the diaphragm may put pressure on this vessel, which can lead to ischemia here, and that can lead to strangulation in this area, or sometimes even perforation. If the stomach has gone into the thorax, whether it is sliding or paraesophageal, patient may present with chest pain, and obviously the stomach may be putting pressure on the lungs, so patient may have difficulty in breathing. We can take a chest x-ray. When we take a chest x-ray, we can find this air fluid level in the thorax. So this simply indicates that this is hiatus hernia. Looking at the x-ray, we cannot say where is the GE junction. For that, we prefer doing a CECT, or if not CECT, then barium meal. And if we find that, suppose this is the diaphragm, and if the G junction is in the thorax, that means this is a sliding hiatus hernia. But if suppose there was fundus of the stomach in this area, or maybe more portion of the stomach in this area, and the G junction would have been in the abdomen, then it would have been a paraesophageal hiatus hernia. In the treatment for all the hernias, conceptually the story is same, that we have to bring the herniated content back into its original place and then put a barrier so that it does not go out again. So we can simply bring the stomach back into the abdomen, wrap the fundus of the stomach around the lower esophagus, that is fundoplication. However, in paraesophageal hernia, we also will have to do something for that weakness in the diaphragm. If we talk about esophageal ruptures or esophageal perforations, there are two stories. One is iatrogenic esophageal perforation, which is much more common during endoscopy, and they are seen near the cricopharynx, because cricopharynx is the narrowest part. So during endoscopy, maximum resistance is near the cricopharynx, right? These iatrogenic perforations are generally small and they can heal spontaneously, so they does not require any operative correction. We just follow the conservative guidelines, leave a nasogastric tube for 5 to 7 days, and these perforations can heal. However, a rare variety of esophageal rupture is Bohr-Havi syndrome, which is also called as barotrauma. This is spontaneous esophageal perforation, मतलब अपने आप esophagus फट जाता है. Now, this story is seen generally when the stomach is full and there is forceful vomiting, especially in elderly people, because that forceful vomiting will generate more pressure in the esophagus and then the esophagus can rupture. Say, for example, binge drinking, binge eating, एक बार में ज़्यादा खाया या ज़्यादा पिया. Now, because of this binge drinking or binge eating, the stomach is full, the pressure inside the stomach will be more, and there might be forceful vomiting. If this forceful vomiting causes high pressure in the esophagus, which causes rupture of the esophagus, then this is Bohr-Havi. But if suppose after binge drinking or binge eating, there is forceful vomiting, high pressure, which causes mucosal tear in the gastroesophageal junction, which will bleed hematomasis, then that is Mallory-Weiss tear. Esophageal varices would be related to portal hypertension, and portal hypertension story would be related to some cirrhosis of liver, especially in chronic alcoholics. So when the lower esophageal veins become abnormally dilated, tortuous in the esophagus, then sometimes there is a possibility because of a slight trauma they can bleed and patient presents with hematomasis. In such cases, first of all, we have to stabilize the patient, IV fluids. Once the patient is stabilized, then we can do endoscopy and do a endoscopic variceal ligation for bleeding esophageal varices. Though we can use some medicines like octreotide and others before we are doing this endovariceal ligation in the stabilization phase. And then definitely we'll have to do something for portal hypertension and cirrhosis of liver as well. Right, so coming to this Bohr-Havi syndrome, after binge drinking or binge eating, forceful vomiting, high pressure, this high pressure can rupture the esophagus at the weakest point, that is on the left side in the posterolateral wall, because of which all the gastric contents will leak into the mediastinum suddenly, wherein maybe the food or the drinks which he has taken, that would be going into the mediastinum, plus air will be going into the mediastinum, and this air will be seeping through the layers of the chest wall and come to lie below the skin, that is subcutaneous emphysema. So we can make a Meckless triad of vomiting, chest pain and subcutaneous emphysema. Now because this esophagus is rupturing on the left side, so the contents are leaking towards the left side, patient present with sudden onset of severe left-sided chest pain radiating to the left shoulder and the left arm. If by chance there is mediastinitis and patient is going into septicemia or maybe shock type of situation, then the first and foremost duty is to stabilize the patient. Imagine a 60-70-year-old gentleman coming to us in the emergency 2 o'clock in the night with sudden left-sided chest pain, and suppose he is in a state of shock, then first we have to give IV fluids, start IV antibiotics, get the ECG done as quickly as possible, get the cardiac enzymes done, rule out the cardiac event. Once the cardiac event is ruled out, and once by your IV fluids the patient has become stable, you do the clinical examination on auscultation. If there is air beneath the skin, it gives a sound as if somebody is walking on the snow, footsteps on the snow. That is called as Hammond's crunch or mediastinal crunch or Hammond's sign. Remember, Hammond's and Moses sign, they are seen in deep vein thrombosis, but Hammond's sign is seen in Bohr-Havi syndrome. We can take a chest x-ray which can show us pneumomediastinum. However, best would be doing a CT scan with contrast, where if any GI perforation is suspected anywhere in the GI tract, please don't use barium, because barium is hypertonic. It will leak through the perforation and will cause significant injury to the surrounding organs. So we prefer using water-soluble contrast like gastrograph, and we use iohexol. And when we are giving the contrast, this will be showing us the exact size and the site of perforation. And we can find leakage of contrast in the mediastinum. Because patient is having mediastinitis, septicemia type of story, agreed that we are giving IV fluids, IV antibiotics, but the dose of IV antibiotics may not be sufficient to take control of such a big bacterial party in the mediastinum. So we need to do a thoracotomy and do a nice mediastinal lavage. 10 liter, 20 liter normal saline. अच्छे से झाड़ू पोछा लगाना है, स्वच्छ भारत अभियान. This mediastinal lavage will be life-saving for the patient. And then decision whether to close or not to close the perforation depends on the amount of contamination. If the patient presented to us early, within 4 to 6 hours, the contamination will be less, we can close the perforation. But if the patient has come to us late, after 4 to 6 hours, there would be cross contamination, and then we cannot close the perforation. We just leave a drainage tube. If we look at the foreign bodies in the esophagus, then these foreign bodies, if we look at a small baby, commonly we see coin. In adults, we see food bolus like fishbone, and in elderly people, they are loose teeth or the dentures. If the baby has swallowed the coin, majority of the time, this coin will negotiate the cricopharynx, which is the narrowest part in GIT. And if the coin has negotiated the cricopharynx, then this coin is going to pass down through the entire GIT and out spontaneously. No intervention is required generally. But by chance, suppose the coin is there at the cricopharynx And if you take a X-ray and you find the coin near the cricopharynx, you can simply do endoscopy or esophagoscopy and you can retrieve this coin. If there is a food bolus getting stuck in the esophagus, we encourage giving fizzy drinks to the patient, and that will help in breaking the food because of gas. The fizzy drinks, soda drinks, gas will break the food bolus and food bolus will disintegrate and it will pass down. How to differentiate the ENT thumb rule FFF story which Sir has told or detailing. So if you see a circular foreign body on front X-ray, that is in the esophagus. But if you see a linear shadow on front X-ray, then it is in the trachea. Opposite will be on the lateral X-ray. So you have to just remember one thing. For example, if you are seeing a circular shadow on front X-ray, this is esophagus. Lateral X-ray, opposite. Trachea, front X-ray, opposite. Lateral X-ray, same to same. So you can just remember one thing. Now, if we look in the abdomen, in the epigastrium, then we'll talk about gastritis and peptic ulcer stories. Gastritis can be classified as acute, chronic and special. Acute, which is sudden in onset, severe in presentation, carries high mortality, and we have to be aggressive in emergency in managing and saving the life of these patients. Chronic, which is present for a long period of time, sometimes present in OPD, we have got sufficient time to investigate and plan the treatment electively, and there can be some special types. Acute gastritis is because of sudden insult to the gastric mucosa, maybe because of non-steroidal anti-inflammatory drugs, smoking, Helicobacter pylori, or alcohol. 4 bottle vodka in the stomach may cause multiple erosions in the stomach mucosa which can bleed, and patient can present with hematomasis or melena or both. The commonest reason for hematomasis would be peptic ulcer, where duodenal ulcer bleeds are more common. However, hematomasis can be because of gastric erosions, it can be because of Mallory-Weiss tear, it can be because of esophageal varices as well. If we look at what is the basic difference between Bohr-Harvey, Mallory-Weiss and esophageal varices, Bohr-Harvey, it is rupture of the lower esophagus. Mallory-Weiss is a mucosal tear at the G junction in the stomach. And esophageal varices, these are dilated tortuous varicose veins in the lower esophagus. In Bohr-Harvey and Mallory-Weiss, the game is binge drinking or binge eating and forceful vomiting. That can cause either mucosal tear or esophageal rupture. But in esophageal varices, it is not a binge drinking or binge eating story, it is a chronic alcoholic story. And because of that, cirrhosis, portal hypertension, these esophageal varices are there. So Bohr-Harvey is basically transmural perforation. Mallory-Weiss is mucosal and varices are mucosal, submucosal. Mallory-Weiss and esophageal varices present with hematomasis, while Bohr-Harvey will present with chest pain, left-sided. How to approach a patient of hematomasis? We can expect that patient might have lost significant amount of blood. So the volume in the pipeline would be going down, pressure in the pipeline is going down, oxygen supply to the vital organs is going down, and this patient can die. So first and foremost is we have to save the life of this patient. So we have to generate pressure in the pipeline by giving IV fluids, where we prefer giving crystalloids and not colloids. Why not colloids initially? Especially till the time the blood vessels are leaky. We avoid colloids because if you give colloid will leak from the site of bleed and colloid will go into the extravascular space. There it will exert the oncotic pressure and will drag more intravascular fluid into the extravascular space, further aggravating hypovolemia and hypotension. So till the time the leak in the blood vessel stops, it is better to give crystalloids like normal saline, Ringer lactate or Hartmann solution. Now, when we are pumping in this fluid, it will generate pressure in the pipeline and oxygen can be supplied. But if there is more than 30% of blood loss, which can be calculated by various parameters, which we'll be discussing in the trauma section. If more than 30% of blood loss is there, then more than 30% of hemoglobin is lost, more than 30% of platelet clotting factors are lost. So, if you're just giving IV fluid, you may be able to generate some pressure in the pipeline, but if hemoglobin is not there in the pipeline, then who is going to carry oxygen to the vital organs? So, you need to give RBCs. You need to give platelets clotting factors which will help in stopping the bleed. And we also need to give tranexamic acid injection which will help in stopping the bleed. So if there is more than 30% of blood loss, apart from IV fluids, we also give blood transfusion and tranexamic acid. If this is able to control the bleed, if this is able to generate sufficient pressure in the pipeline, if sufficient oxygen is supplied to the vital organs, wonderful. We can do endoscopy and try to figure out where is the bleeding vessel. If you see bleeding vessel on endoscopy, then you can deal with that bleeding vessel by various methods. You can push sclerotherapy or adrenaline, or you can burn that vessel, or you can put the clips. Like in esophageal varices, we are doing endoscopic variceal ligation using the rubber bands. If the bleed is not from the mucosa, then endoscopy may not show the bleed. Then there is a possibility bleeding from the submucosa or muscle behind the mucosa, which will not be seen on endoscopy. So there we do angiography. In angiography, we are putting a catheter or cannula into the artery, pushing the contrast. Contrast will travel in the entire pipeline, and wherever the pipeline leak is there, the contrast will come out from the leak site. And then during that angiography only, we can pass a Fogarty catheter, which is used in vascular surgery, load a embolus on Fogarty catheter like a coil, and we can stop the bleeding through angiography by putting a coil at the site of bleed. That is angioembolization or therapeutic embolization. There may be some instances wherein, despite giving IV fluids or blood transfusion, tranexamic acid, the bleeding is not getting controlled. Probably it's a huge amount of bleed. Whatever normal saline blood you are pumping in or Trenexa you are giving, all that is also leaking out. Then this patient will die very soon unless and until some drastic step is taken. If despite pumping in IV fluids blood Trenexa, the pressure in the pipeline is not coming up, it means there is significant leak. Do not wait for anything. Open that area directly and apply direct pressure at the bleeding site. Best method to control bleeding is direct pressure, and that direct pressure will help in stopping the bleed. Now you pump in IV fluids and blood, which will increase pressure in the pipeline and will supply oxygen to the vital organs. That is how we need to play the game. Chronic gastritis. Chronic gastritis can be classified as type A and type B. A is for antibodies, that is autoimmune. This is atrophic gastritis. Antibodies are formed against the parietal cells and they do not allow the parietal cells to work. So HCl secretion goes down, intrinsic factor goes down. Intrinsic factor goes down, there will be defective absorption of vitamin B12 leading to pernicious anemia. HCl goes down, that is hypochlorhydria. That will stimulate the G cells to produce more gastrin, hypergastrinemia. The common cause of hypergastrinemia is overuse of PPIs. Now, despite high gastrin, the parietal cells will not be able to release acid because the antibodies have blocked the parietal cells. So, changes develop in the parietal cells gradually, adenomas develop in the parietal cells, and cancer can occur, adenocarcinoma, at the fundus of the stomach in pernicious anemia. Type B gastritis is related to the bacteria Helicobacter pylori. Now this bacteria can cause stomach as well as duodenal problems. Reason for stomach problem is disruption of the gastric acid mucus barrier. This bacteria produces toxins like CAGE, VACE, proteases, phospholipases, which disrupt the gastric acid mucus barrier, and that can cause gastritis, gastric ulcer, or even gastric cancer. This bacteria also produces an enzyme urease, which split urea into ammonia. Ammonia is alkaline. If there is more alkali inside the stomach, then the parietal cells will start producing more acid to neutralize this alkali. And when more acid secretion is there, if the stomach mucus barrier is intact, this more acid will go towards the duodenum and will hurt the duodenal mucosa, especially in the first part, and lead to duodenal ulcer. Whether it is gastric story or duodenal story, the patient generally presents with epigastric pain, and our clinical approach in epigastric pain, first we try to modify the lifestyle of the person, and then we give PPIs. PPIs will block the acid secretion, increase the pH. So whatever problems patient was having because of acid damage to the gastric ulcer or to the duodenal ulcer, that damage will be less and the patient symptoms may decrease. However, in gastric ulcers, we should add other medicines which can protect the stomach mucosa. But here we are talking about bacterial story. So just by giving PPIs, patient's symptoms may decrease, but they will not disappear because bacteria is still active. So patient will keep on coming with the symptoms. We can do endoscopy. On endoscopy, if we find an ulcer in the stomach, we take a biopsy from two areas. If we find ulcer in the duodenum, we take biopsy from the prepyloric region in the stomach. And this biopsy specimen is given to the pathologist, where he can use Giemsa stains, Athens Starry silver stains to diagnose H. pylori. Pathologist can do a rapid urease test, that is CLO test, Campylobacter-like organism test on this biopsy specimen. Or we can also do a urea breath test, where radio labeled 13 carbon, 14 carbon is given in a special urea capsule. And if H. pylori is active in the stomach, then this urea is broken to ammonia. Ammonia will be absorbed in the circulation, and through the circulation it will come to the lungs and will be excreted in breath, which we can measure through breath analyzer and confirm this H. pylori. If this bacteria is confirmed, then yes, we have to give the eradication therapy to eradicate this bacteria, which can be a triple drug therapy, quadruple therapy, or sequential therapy. In triple drug therapy, we give 2 antibiotics and 1 PPI for 14 days, that is amoxicillin, clarithromycin, and omeprazole. In quadruple therapy, we add bismuth subcitrate. There can be special gastritis like Menetrier's disease, where there is gross hypertrophy of the gastric mucosal folds, and that is pre-malignant. We can come across reflux gastritis sometimes, that is whenever we are doing any gastric surgery, then if the distal part of the stomach is removed, that is the pyloric sphincter is removed, then the gastric secretions, they will be going into the jejunum, right? But the jejunal alkaline secretions will be refluxing back into the stomach, which will cause damage to the stomach mucosa. And this will cause reflux gastritis or alkaline gastritis. If this reflux continues, then the stomach mucosa would want to become like jejunal mucosa. So this gastric columnar will change to intestinal columnar. That means there will be intestinal metaplasia in the stomach, which carries high risk of adenocarcinoma. If we look at the peptic ulcers, the commonest site for peptic ulcer is the first part of duodenum. The second commonest site is the lesser curvature of the stomach. However, rare sites can be lower esophagus, stoma of gastrojejunostomy, and Meckel's diverticulum. The commonest cause of peptic ulcer is Helicobacter pylori. However, various non-steroidal anti-inflammatory drugs, smoking, spirits, spices, stress, steroids, and syndrome like Zollinger-Ellison syndrome or gastrinoma. Peptic ulcers seen in head injury patients are Cushing ulcers. Peptic ulcer in burn patients are curling ulcers. Skin ulcer in burn patients are Marjolins ulcer. If we see the difference between duodenal and gastric ulcer, duodenal ulcers are much more common than gastric ulcer. Duodenal ulcers are seen more commonly in young people, rich people, and duodenal ulcers are smaller. Gastric ulcers commonly seen in poor people, old people, and they are larger. The basic pathogenesis, duodenal ulcer is related to high acid secretion. So acid secretion will always be high in duodenal ulcer. But gastric ulcer is because of disruption of the gastric acid mucus barrier. So acid secretion can either be normal or even be low in gastric ulcer. Whether it is duodenal or gastric ulcer, patient will present with epigastric pain. However, if this epigastric pain occurs 2 to 3 hours after meals, and this is getting relieved by taking more food, then this is duodenal ulcer. While if the epigastric pain occurs immediately after meals, and this is getting relieved by vomiting, then it is gastric ulcer. Because duodenal ulcer pain is getting relieved by food, so duodenal ulcer patients tend to eat more. Their appetite and weight increases. Gastric ulcer patients, they feel pain immediately after eating and they get relieved by vomiting. So actually they develop food fear. They don't want to eat because eating food will cause pain. So appetite weight decreases in gastric ulcer. O blood group patients have more chances of duodenal ulcer. A blood group patients have more chances of gastric ulcer. Spelling of duodenum, D-U-O. Spelling of gastric, G-A. How to approach this epigastric pain? The same story. We advise lifestyle modification. If this is not successful, we give PPIs, the gold standard treatment for all acid-related disorders. 90-95% of patients will be successfully treated by PPIs. Why? Because by giving PPI, you are reducing the acid secretion, so there is nobody who is irritating the ulcer now, and the ulcer will heal by the natural healing process in the body. In gastric ulcer patient, we also give sucralfate, which forms a coating on the surface of stomach mucosa, which does not allow the stomach acid to come in contact with the stomach mucosa. If PPI fails, then we do endoscopy. Depending on what we find on endoscopy, we proceed accordingly. If on endoscopy you find a problem in the lower esophagus, you think on the lines of GRD, you do a 24-hour ambulatory pH monitoring where if Demister scoring is positive, then you consider fundoplication. If you find an ulcer in the stomach, you should take biopsy from two areas, one from the ulcer, one from the prepyloric. If you find ulcer in the duodenum, take a biopsy from the prepyloric. If H. pylori turns out to be positive, give eradication therapy, triple drug therapy for 14 days, 2 antibiotics, 1 PPI, amoxicillin, clarithrol, and omeprazole. If by chance the patient symptoms recur, then you consider reinfection with H. pylori and you give re-eradication therapy. If the patient symptoms recur again, then you have tried your level best with the medicines. You earlier gave PPIs, you have given eradication therapy 2 times, which also had PPIs, and still the patient is not getting significant relief. Then you consider doing surgical treatment. Though surgical treatment is rarely done now for peptic ulcers. However, when we have to do surgery, then for a duodenal ulcer, we focus on reducing the acid secretion, while for gastric ulcer, because they can become malignant, we focus on removing that portion of the stomach which is having the ulcer. For duodenal ulcer, to reduce the acid, we can chop the vagus nerve because vagus nerve is stimulating the parietal cells to release acid. We can do different types of vagotomies like truncal vagotomy, selective vagotomy, and highly selective vagotomy. Highly selective vagotomy or parietal cell vagotomy, that is considered as the surgical treatment of choice for duodenal ulcer, because in highly selective vagotomy, we are not damaging the motor fibers. So the motility of the stomach will not be affected and no drainage operation will be required. But if we are doing a selective vagotomy or a truncal vagotomy, we are disturbing the motor fibers also. So motility of the stomach will decrease and we'll have to do a drainage operation, either pyloroplasty or gastrojejunostomy. The chances of recurrence of duodenal ulcer out of these three types of vagotomies will be maximum in highly selective vagotomy and will be minimum in truncal vagotomy. Surgery for gastric ulcers, we have to remove that portion of the stomach. So we do a Roux and Y gastrojejunostomy, which is a modification of Billroth 2. Billroth 1 was gastroduodenostomy and Billroth 2 was simple loop gastrojejunostomy. But if we are doing a simple Billroth 2 loop gastrojejunostomy, the bile and pancreatic secretions will reflux into the stomach, cause more damage to the stomach. So we prefer making a Roux loop and we do a Roux and Y gastrojejunostomy. There can be some complications of this peptic ulcer surgery. For example, there can be duodenal stump blowout which occurs on 4th postoperative day. There can be dumping syndrome, that is post-Seibel syndrome, early dumping or late dumping. Early dumping is seen within 5 to 10 minutes after taking meals. For example, if the patient takes a rasgulla, then because there is no pylorus, it is not going to stay inside the stomach. This will move quickly down into the jejunum. And this rasgulla will create a problem in the jejunum. Because it has not been broken down, so jejunum will send signals to the entire body to send as much fluid and blood to break this rasgulla, digest and absorb this rasgulla. So within 5 to 10 minutes after meals, there is migration of fluid and blood from the peripheries towards the intestine, because of which the intestines, they are filled with fluid and blood. Patient experiences bloating sensation, epigastric pain, abdominal cramps, nausea, vomiting type of feeling, diarrhea, and the peripheries are becoming cold, tachycardia type of thing. This is early dumping syndrome. Due to high osmotic load within the intestine, it appears within 5 to 10 minutes after meals and it can last for maybe half an hour, 1 hour or 2 hours. In the second hour after meals, we find late dumping syndrome. That is, when this rasgulla is broken in the jejunum, there is suddenly more amount of glucose coming into the blood, especially in the second hour after meals. This will suddenly increase the blood glucose level, which can overstimulate the pancreas to produce excess insulin. And this excess insulin, whatever insulin was required, that will be consumed, but that excess insulin will cause hypoglycemic symptoms. So this is reactive hypoglycemia, fainting and all that stuff. This will be seen usually in the second hour after meals. And we know to correct hypoglycemia, again, we have to give food to this patient. So we advise these patients not to take bulky meals after this gastric surgery. It is better to take small, frequent meals so that the jejunum is not overstimulated by that bulky food. Apart from dumping, there can be post-vagotomy diarrhea, there can be nutritional deficiencies like iron, vitamin B12, calcium, phosphorus, proteins, and so on. Iron deficiency is because the food is not going into the duodenum, so how the iron from the food will get absorbed? Iron absorption mainly occurs in the duodenum. Vitamin B12 deficiency because you are chopping the parietal cell mass, so intrinsic factor will decrease and that will result in B12 deficiency. Oral supplementation of iron B12 is not going to be helpful, because even if you give iron tablet to the patient, this tablet will be going down like this and iron will not be absorbed. So we have to give injectable supplements for this iron and B12 in these patients. There will be high risk of gallstone formation after peptic ulcer surgeries because of denervation of the vagal motor fibers to the gallbladder, which will decrease the motility of the gallbladder, stasis of bile in the gallbladder, stasis infection stone in the gallbladder. And there will be high chances of gastric cancer in the residual stomach because of reflux of jejunal contents in the stomach, which will cause reflux gastritis, alkaline gastritis, intestinal metaplasia, and adenocarcinoma of the stomach. Complications of peptic ulcer per se: bleeding, perforation. Ulcers which are situated on the posterior surface of the first part of duodenum have more chances of bleeding. And this bleeding is from the gastroduodenal artery, especially in duodenal ulcers. Gastric ulcer bleeding is rare. If gastric ulcer has to bleed, then it is commonly from left gastric artery. Ulcers which are situated on the anterior surface, they have more chances of perforation. And if the ulcer perforates, the gastric duodenal contents will leak in the peritoneal cavity, will cause peritonitis, risk of septicemia and death. These patients will present with diffuse abdominal pain. When these patients come in the emergency, maybe in a shock-like condition, tachycardia, tachypnea, hypotension, you have to pump in IV fluids, you have to give IV antibiotics. To generate pressure in the pipeline, you are giving IV fluids. Try to make these patients stable. Once the patient becomes a bit stable, do a clinical examination where you will find diffuse tenderness all over the abdomen. There will be diffuse guarding and cardboard-like rigidity all over the abdomen. In peritonitis, perforation peritonitis, we find this diffuse abdominal guarding rigidity. We are suspecting peptic ulcer perforation. We can take a X-ray. We take a chest X-ray in standing position if possible, because any GI perforation, any hollow viscous perforation in the abdomen, the free air will leak in the peritoneal cavity, pneumoperitoneum. And if you are taking an X-ray in a standing position, this gas will be rising up. In this chest X-ray, you should always include both the domes of diaphragm. If you find free gas below the diaphragm, this indicates hollow viscous perforation. If you are taking the X-ray, suppose in supine position, then you find this gas below the midline. If you are taking the X-ray in supine position in a lateral position, then it is preferred that you make the patient lie in the left lateral decubitus position so that gas rises towards the right side and you see the gas below the right dome of the diaphragm. Why we don't prefer to look below the left dome of the diaphragm? Because already there is normal gastric shadow, gastric bubble on the left side. To confirm what is the site of perforation and all, the best investigation would be CT scan if the patient is absolutely stable. Because we know that whatever IV antibiotics we are giving to this patient, the dose of IV antibiotic may not be sufficient to take control of such a big party in the peritoneal cavity. So patient may die because of septicemia. So in such cases, it is better that we do laparotomy, do a nice peritoneal lavage, 10, 20, 30 liter normal saline. This peritoneal lavage will be life-saving for the patient. And then decision whether to close or not to close the perforation will depend on the amount of contamination. If patient came to us early, within 24 to 48 hours, then we can close the perforation by putting the omental patch or the Gram's patch. But if the patient came to us late, after 24 to 48 hours, the contamination may be more and we just have to leave the drainage tubes. In this perforation peritonitis story, when you find this gas under diaphragm, the stepwise algorithm says that first make the patient stable by giving IV fluids, IV antibiotics, put the nasogastric tube, put the urinary catheter, give analgesia, try to stabilize the patient. Then you go for investigations, maybe X-ray or maybe CT scan, and then you do a laparotomy where you do the lavage. Decision whether you have to close the perforation or you have to just leave the drainage tubes or you have to bring that loop out of the abdomen depends on the amount of contamination and the site of perforation. The various bezoars trichophyto and lactobacillus, trichoheads inside the stomach, common in young psychiatric females. Phyto vegetable matter in the stomach, lactato milk products inside the stomach. They are seen whenever the stomach motility goes down. Phyto and lactobacillus, they are seen when the stomach motility goes down. This can be seen in prolonged immobilization or maybe after gastric surgery. Bariatric surgery, which is surgery for morbid obesity. This is a metabolic surgery and not a cosmetic surgery, and it is indicated if the body mass index is more than 40 or body mass index is more than 35 associated with comorbidities like diabetes mellitus, hypertension, osteoarthritis, sleep apnea syndrome, coronary artery disease, cerebrovascular accidents, and so on. Most effective bariatric surgery is Roux and gastric bypass. However, preferred, most commonly performed is sleeve gastrectomy. We can do a vertical banded gastroplasty, and an adjustable bariatric surgery is laparoscopic adjustable gastric banding. Right. Now, let's revise this with the closed eyes. Let me come on the big screen now. Right. My dear lovely friends, if we look at the adult surgical problems, starting from top to bottom, Zenker's diverticulum. Zenker's diverticula is acquired diverticula which occurs in elderly people. This is basically protrusion of posterior pharyngeal wall above the cricopharyngeal sphincter through the Killian's dehiscens, that is the inferior constrictor muscle between the oblique thyropharyngeus and the transverse cricopharyngeus fibers. This posterior pharyngeal wall protrudes posteriorly, and this is Zenker's diverticulum or the pulsion diverticulum or the cricopharyngeal ecclesia or the pharyngeal pouch. In 50% of patients, it is associated with cervical webs. Generally presents between 25 to 40 years of age. Cardinal symptom is dysphagia, which can lead to regurgitation, aspiration, pulmonary complications, and halitosis. When we try to reduce this swelling, which may be on the left side of the midline, it produces a characteristic gurgling sound because of mixing of air and liquid, that is Boyer's sign in Zenker's diverticulum. Dryer's sign is seen in laryngocele. To confirm the Zenker's diverticula, we can do a barium swallow, and in the treatment, if the diverticula is small, less than 2 cm, we just do a cricopharyngeal myotomy, 2 to 4 cm diverticulopexy, and for bigger Zenker's diverticula, we do a Dollmann's operation, which is diverticuloesophagostomy using a linear stapler. Ecclesia cardia. The term ecclesia means failure to relax. Lower esophageal sphincter fails to relax due to unopposed action of acetylcholine. Plus, there is absence of ganglion cells in the esophagus, so that esophageal peristalsis is absent. This can be classified as primary, secondary, and pseudoecclesia. Primary, when the cause is not known, it is not associated with any other disease. Secondary, when it is associated with other diseases like Chagas disease, diabetes, and scleroderma. And pseudoecclesia is when there is no pathology of the esophagus, but there is pathology outside the esophagus which is pressing the esophagus, like mediastinal tumors or tumors of cardia of the stomach. These patients generally present between 25 to 40 years of age. However, Zenker's diverticular patient, they present elderly, more than 50 years of age. Ecclesia 25 to 40 years of age. Patient presents with dysphagia, initially more for liquids, gradually for both liquids as well as solids. Why not initially for solids? Because the solid food, because of their weight, can relax the lower esophageal sphincter and pass down. There may be halitosis, there may be regurgitation, aspiration, pulmonary complications, there can be esophagitis, there can be squamous cell carcinoma developing in the middle one third of esophagus. Right. Patient of dysphagia, our clinical approach would be we get a barium swallow done and we find a classical bird beak or pencil tip appearance, rat tail appearance, and absence of gastric air bubble. In cancer esophagus, we find a filling defect and a rat tail appearance and sometimes apple core appearance, which is more commonly seen in colon cancer. That means rat tail appearance can be seen in both eclasia as well as cancer. If you have to choose one option, then cancer esophagus is a better answer for rat tail appearance. Because there can be different motility disorders, and if you have to segregate those different motility disorders, the standard investigation in eclasia will be esophageal manometry, where we measure the intraesophageal pressure. Normally it is 10 to 25 millimeter of mercury, eclasia 25 to 100, nutcracker 180 to 200, and diffuse esophageal spasm more than 300 to 400. However, when we talk about multi-peaked contractions, in diffuse esophageal spasm more than 120 millimeter of mercury amplitude, and in nutcracker more than 180 millimeter of mercury amplitude. Diffuse esophageal spasm on barium swallow gives a classical corkscrew appearance. The treatment of eclasia, initially we can try giving medicines like calcium channel blockers and nitrates, but results are not very encouraging, so we can try doing a pneumatic balloon dilatation which carries the risk of rupture. However, this is a temporary procedure because again there are chances of stenosis, so a permanent solution of the treatment of choice would be surgery, where we have to do a myotomy. If we are doing by open laparoscopic surgery, that is Heller's operation, where we can also do a fundoplication at the same time if there are chances of reflux. However, nowadays what we are preferring is endoscopic without any incision, that is POEM, per oral endoscopic myotomy, but we cannot do fundoplication at the time of POEM. If patient develop GRD later on, then we have to do additional fundoplication later on. Schatzki's ring, this is a circumferential mucosal submucosal thickening at the squamocolumnar junction seen in GRD patients, can lead to intermittent dysphagia. Generally, no treatment is required, but if patient is coming with symptoms again and again, we do endoscopic dilatation. Single endoscopic dilatation is curative. There can be lye stricture in the esophagus due to ingestion of castics or alkalis, which will initially require maybe feeding jejunostomy for nutrition purpose, and later on electively we can plan the resection of the esophagus and reconstruction using the jejunum. GRD and GR. GR is just gastroesophageal reflux, which is normal. That means normal individuals can have gastric refluxes up in the esophagus for 3 to 4% of times in 24 hours. But when the frequency of these refluxes occur for more than 3 to 4% of times in 24 hours, then we call it as disease. Why normal people does not suffer from GRD? Because of three things: integrity of lower esophageal sphincter, good gastric emptying, and good esophageal peristalsis. If refluxes have to occur, they'll be more common in a head low position, like out of standing, sitting, and supine. Supine position refluxes will be maximum. Why somebody suffers from GERD? Whenever lower esophageal sphincter gets damaged, like most important risk factor is smoking, or maybe alcohol, chai, coffee, hot liquid, spicy food, obesity, progesterone, calcium channel blockers, nitrates. They will weaken the lower esophageal sphincter, and then this acid from the stomach will keep on refluxing into the esophagus. pH inside the stomach is 1.5 to 2. pH in the esophagus is 5 to 7. If pH in the esophagus falls below 4, then we consider it as pathological. So if there is frequent 1.5 or 2 pH going into the lower esophagus, it will burn the lower esophagus and patient presents with retrosternal discomfort or heartburn. Heartburn is the cardinal symptom of GRD. There may be regurgitation, there may be gastric pain. How to approach these patients? First, we do lifestyle modification. We ask the patient to reduce stress, stop smoking alcohol, chai, coffee, hot liquid, spicy food, reduce weight. Do not lie on the bed immediately after meals. Wait for 3 to 4 hours before lying on the bed after meals. And keep the head end elevated by 5 to 8 inches when you are lying supine. If lifestyle modification does not work, then the gold standard treatment for all acid-related disorder would be PPIs. We block the acid secretion. We try to increase the pH. If we are able to increase the pH to around 5, even if the reflux occurs, it is not going to cause damage to the esophagus and the patient's symptoms are sorted. Rarely, PPI may not be able to control the symptoms completely. And if PPI also fails, then we have to find out what is the cause of this epigastric pain. Sorry. For this, we do upper GI endoscopy, and depending on what we find on endoscopy, there may be a problem in the lower esophagus or in the stomach or in the duodenum which is causing epigastric pain. If you find a problem in the lower esophagus, like red hot lower esophagus, you are thinking on the lines of GERD. Endoscopy cannot conclude GERD, because if you see a reflux on endoscopy, then also we cannot write in his report that he is suffering from GERD, because these refluxes can occur for 3 to 4% of times in normal individuals. If you have to label that patient is suffering from GERD, then you have to demonstrate that frequency of refluxes in 24 hours is more than 3 to 4% of times. So you will have to do a study for 24 hours. That is why the gold standard investigation of choice for GERD is 24-hour ambulatory pH monitoring. If there is drop in pH below 4 for more than 4% of times in 24 hours, which we call as D-Meester scoring, then yes, we say that this is GERD. So investigation of choice for GERD is upper GI endoscopy. But gold standard investigation for GERD is 24-hour ambulatory pH monitoring. Once the diagnosis is proved that it is GERD and we have tried medicines earlier, they are not working, so the only option left is surgery. And in surgery, to prevent reflux, we do a floppy Nissen's fundoplication, where we take a 360-degree wrapping of the fundus of stomach around the lower esophagus. If suppose epigastric pain patient not settling with PPIs, we do endoscopy, and if esophagus is normal, then we try to look in the stomach or the duodenum. If you find an ulcer in the stomach, you should take biopsy from 2 areas. One from the ulcer to rule out cancer, one from the prepyloric region to rule out bacteria. If on endoscopy you find an ulcer in the duodenum, then take biopsy from prepyloric region to rule out bacteria. Why we take biopsy from gastric ulcer and not duodenal ulcer? Because gastric ulcer should be considered as malignant unless proven otherwise, while duodenal ulcers hardly ever become malignant. Right. There can be complications of GERD. Most common is esophagitis in the lower esophagus. Healing fibrosis can lead to stricture in the lower esophagus, which can cause shortening of the esophagus. Sometimes there can be Barrett's esophagus and sliding hiatus hernia. Barrett's esophagus is intestinal columnar metaplasia of squamous mucosa of the lower esophagus. Because of continuous acid reflux from the stomach into the lower esophagus, continuous damage of the squamous mucosa, the lower esophageal squamous mucosa want to protect itself and want to have that gastric acid mucus barrier. So there is conversion of the squamous to columnar, which will be having goblet cells. And this will not be gastric columnar. It will be intestinal columnar, which has got more goblet cells than gastric columnar. So it is intestinal columnar metaplasia of squamous mucosa of the lower esophagus, and the hallmark of Barrett's is presence of goblet cells in the esophagus. In this case, the squamo-columnar junction will move upwards, and there is very high risk of adenocarcinoma in the lower esophagus. The treatment for Barrett's would be, if there are highly dysplastic areas, we do endoscopic mucosal resection of the dysplastic mucosa, followed by radiofrequency ablation or argon photocoagulation, and give aggressive PPIs. Sliding hiatus hernia should be differentiated from paraesophageal or rolling, or sometimes called as giant hiatus hernia, when say more than 50% of the stomach is going into the thorax, or not only stomach but some other organs along with the stomach are going into the thorax. That is giant hiatus hernia. Commonly we find sliding hiatus hernias. They are associated with GRD. In GRD, because of refluxes, the G junction start moving up in the thorax. So if you find G junction in the thorax, that is sliding hiatus hernia. Paraesophageal is because of weakness in the diaphragm, wherein the fundus of the stomach goes into the thorax while the G junction remains within the abdomen. So just by locating the G junction, if it is in the thorax, it is sliding. If it is in the abdomen, but the other portion of the stomach in the thorax, then it is paraesophageal. The chances of complications are high in paraesophageal, like ischemia, strangulation, perforation. Whether it is sliding or paraesophageal, patient can present with chest pain and dyspnea, difficulty in breathing. We do a chest x-ray, but chest x-ray will not confirm the location of G junction. So we'll not be able to differentiate on chest x-ray whether it's sliding or paraesophageal. So investigation of choice should be CECT. Or we can even do a barium meal, which can clearly demonstrate the location of G junction and will tell us whether it is sliding or paraesophageal. In the treatment, conceptually, for all the hernias, the treatment is same. Whatever is moving out, you just have to put that structure back into its original place and put a barrier so that it does not go out again. That is fundoplication. You bring the stomach from the thorax into the abdomen, wrap the fundus of the stomach around the lower esophagus. That floppiness is fundoplication. However, in paraesophageal, you also have to take care of the weakness in the diaphragm. Then esophageal ruptures or esophageal perforations. There can be two types. Most commonly, it is the iatrogenic, doctor-induced due to endoscopy. Rigid endoscopes have more chances. And because cricopharynx is the nervous part in the GIT, so during endoscopy, maximum resistance is near the cricopharynx. So these iatrogenic perforations are seen in the upper esophagus near the cricopharynx. And they usually do not require any operative correction. Iatrogenic esophageal perforations are generally small and they can heal spontaneously. We follow a conservative treatment. We just put a nasogastric tube for 5 to 7 days and these iatrogenic perforations can heal spontaneously. However, Bohr-Harvey syndrome or barotrauma or spontaneous esophageal rupture, this is spontaneous. अपने आप esophagus कैसे फट सकता है? Now, this is a story which is commonly seen in elderly people. जैसे जैसे उम्र बढ़ती है, इमारतें कमजोर होती हैं. As we grow old, the tissues become weaker and weaker. So, elderly person, if suppose he has binged in drinking or eating, एक बार में ज़्यादा खाया, binge drinking, binge eating, the stomach will be full, the intragastric pressure will be high, this will lead to forceful vomiting. This forceful vomiting will create very high pressure, and if this high pressure goes in the old esophagus, then esophagus can rupture at the weakest point, that is on the left side posterolateral wall, lower esophagus. And suddenly all the gastric contents will leak into the mediastinum on the left side, causing sudden onset of severe left-sided chest pain radiating to the left shoulder and the left arm, mimicking acute myocardial infarction. Lot of air has also leaked into the mediastinum, which can come below the skin as subcutaneous emphysema. So there is a Meckler's triad of vomiting, chest pain, and subcutaneous emphysema. Also, be careful. After binge drinking, binge eating, Whenever the stomach is full, high intragastric pressure, there can be forceful vomiting. And if this forceful vomiting causes mucosal tear at the gastroesophageal junction in the stomach, this is Mallory-Weiss tear, which can bleed and present with hematemesis. Esophageal varices is a chronic story seen in portal hypertension, like in chronic alcoholic. If there is cirrhosis in the liver, portal hypertension, then the lower esophageal veins will become abnormally dilated, tortuous, which, because of the slightest trauma, can bleed and present with hematemesis. So that is a chronic alcoholic story. Now, this Bohr-Harvey syndrome, when the lower esophagus has ruptured suddenly and patient is presenting with that left-sided chest pain mimicking acute MI, there is a huge amount of bacterial load in the mediastinum, which is carrying the risk of septicemia. Patient may be in shock. How to approach this story in emergency? 60, 70-year-old gentleman after binge drinking, binge eating, forceful vomiting, acute MI type of features, and patient in shock. So first we have to save the life of this patient. We have to generate pressure in the pipeline by IV fluids. We have to give IV antibiotics. Do a quick ECG and cardiac enzymes to rule out cardiac event. Once the patient is stabilized, on auscultation, you may find sounds as if somebody is walking on the snow, footsteps on the snow because of air beneath the skin on auscultation. This is mediastinal crunch or Hammond's crunch or Hammond's sign. We should not confuse with Homans sign. Homans and Moses sign are seen in deep vein thrombosis. We can do a CT scan with contrast, but before that we can do a chest x-ray which can show us pneumomediastinum. Whenever we are using contrast in suspected GI perforations, we have to be careful. We cannot use barium because barium is hypertonic and can cause significant injury to the surrounding structures. So we prefer using iohexol or water-soluble contrast like gastrographin, which will cause minimal injury. The CCT or maybe a barium swallow can give us, not the barium swallow, the contrast swallow with iohexol or maybe gastrographin. This will give us the exact site and size of perforation. Because there is high risk of septicemia due to huge amount of bacterial load in the mediastinum, we should do a thoracotomy, do a nice mediastinal lavage. That will be life-saving for the patient. And then decision for closure, non-closure of the perforation will depend on the amount of contamination. If the contamination was less, then we can close this esophageal perforation. But if the contamination was more, we just leave a drain. Foreign bodies can be seen in the esophagus sometimes, like in small babies, we find coins in the esophagus sometimes. Adults, we find food bolus like fishbone. Elderly people, we find loose teeth and dentures. If the baby has swallowed the coin, majority of the time the coin is able to negotiate the cricopharynx and it goes down and passes out spontaneously. Nothing has to be done. But sometimes the coin may get impacted at the cricopharynx, which on X-ray from the front view looks a circular shadow. Lateral view, linear shadow. Opposite if it is in the trachea. Now, if there is a coin at the cricopharynx, then we do endoscopic, that is esophagoscopic retrieval of the coin. If there is a food bolus impacted at the cricopharynx, we give fizzy drinks, soda drinks, which liberate gas, and that gas can disintegrate the food bolus and the food bolus can pass down. If we look at the abdomen, in the epigastrium, we focus on gastritis and peptic ulcer. Gastritis can be acute, chronic, and special. Acute, which is sudden in onset, severe in presentation, carries high mortality, and we have to be aggressive in the emergency management. Acute gastritis can be caused by non-steroidal anti-inflammatory drugs, or maybe smoking, or maybe Helicobacter pylori, or maybe alcohol. Suppose 4 bottle vodka. This has caused multiple gastric erosions which are bleeding. Patient can present with hematemesis or melena. The commonest cause of hematemesis are the peptic ulcers, where duodenal ulcers bleed more commonly. However, gastric erosions, Mallory steer, esophageal varices all can present with hematemesis. Clinical approach in a hematemesis patient. If bleeding is going on from anywhere in the body, here we are focusing on hematemesis. Bleeding anywhere in the body, the volume in the pipeline is going down, pressure in the pipeline is going down, oxygen supply to the vital organs is going down. Patient can die. To save the life of this patient, we have to supply oxygen to the vital organs, for which we have to pump in IV fluids. We prefer giving crystalloids like normal saline or maybe ringalactate, or almost close to ringalactate is Hartmann's solution. We avoid using colloids in the initial period of resuscitation, because if we are giving colloids and if the vessel is leaking, the colloid will leak out from the leak site, will go in the extravascular space, will exert the oncotic pressure, and will drag more intravascular fluid into the extravascular space, further aggravating hypovolemia. So if we have the option of giving crystalloid, then that would be the best. Also, if there is more than 30% of blood loss, that means more than 30% of hemoglobin is gone, more than 30% of platelet clotting factors are gone. In such cases, just by giving IV fluids, we are trying to increase the pressure in the pipeline, but if more than 30% of hemoglobin is lost, if there is less hemoglobin in the pipeline, who will carry the oxygen to the vital organs? So we need to give RBCs. We also want the bleeding to stop, so we have to give platelets and clotting factors. We also give tranexamic acid injection, which help in stopping the bleed. We don't want WBCs, so we use leukodepleted blood transfusions. And with IV fluid blood transfusion, we may be able to supply oxygen to the vital organs. The patient is becoming a bit stable. To stop the bleeding further, we can do endoscopy. If we are able to see a bleeding vessel on endoscopy, that means bleeding is from the mucosa, and we can seal that bleeding vessel by sclerotherapy, adrenaline, diathermy, or by clips. If it was a esophageal varices which was bleeding, then after basic resuscitation, ABC story, IV fluids, octreotide and all, then we would have gone for endoscopic variceal ligation with the rubber bands. However, if bleeding is not from the mucosa, then endoscopy may not show us the bleeding site. Then we have to do angiography. In angiography, we put the cannula into the artery and put the contrast. The contrast will be traveling through the entire pipeline, and wherever the pipeline is leaking, the contrast will leak out. And then we can pass a Fogarty catheter into that artery. We load the embolus on the tip of the Fogarty catheter, which is generally in the form of a coil, and we put this coil at the site of bleeding and stop the bleeding. This is angioembolization or therapeutic embolization, which is used very commonly nowadays to control bleeding from the upper GI, lower GI, respiratory, genito, urinary, and so on. Rarely there is a possibility that despite giving IV fluids, blood transfusion, Trenexa, the pressure in the pipeline is not coming up. That is because there is a major leak going on. Whatever you are pumping IV fluid blood Trenexa, that is leaking out from that major leak site, and pressure in the pipeline is not coming up. In these cases, if despite pumping an IV fluid blood Trenexa, pressure in the pipeline is not coming up, that means this patient is going to die very soon. You don't have too much of time. Take this patient in the operation theater, open the abdomen, open the stomach, and apply direct pressure on the bleeding vessel. Best method to control bleeding is direct pressure. Once you apply pressure, once you stop the bleeding, then you ask your assistant to pump in IV fluids and blood transfusion. And now this will generate pressure in the pipeline and supply oxygen to the vital organs. And that is how you will be able to save the life of your patient. Chronic gastritis can be type A and type B. A is antibody story, that is autoimmune. This is atrophic gastritis, where antibodies are formed against the parietal cells. These antibodies does not allow the parietal cells to work. So HCl production goes down, intrinsic factor production goes down. Intrinsic factor goes down, by B12 absorption goes down, pernicious anemia. HCl goes down, hypochlorhydria. This will stimulate the G cells in the antrum and they will release more gastrin, hypergastrinemia. Though a common cause of hypergastrinemia is overuse of PPI nowadays. However, despite more gastrin, which is stimulating the parietal cells to release acid, the antibodies will not allow the acid to be released. So a chronic irritation develops in the parietal cell where adenomas develop, which lead to adenocarcinoma in the fundus of the stomach in pernicious anemia patients. Type B gastritis, B is bacteria story, Helicobacter pylori, which can cause problems in the stomach, problems in the duodenum. The stomach problems are related to disruption of gastric acid mucus barrier. This bacteria produces toxins like GAGA, VACA, proteases, phospholipases, which damage the gastric acid mucus barrier. And that is how the gastric acid comes in contact with the stomach mucosa and cause gastritis, gastric ulcer, and gastric cancer. H. pylori produces urease enzyme which split urea into ammonia. Ammonia is alkaline. The parietal cells will try to neutralize this alkali by secreting more acid. More acid, if the stomach mucous barrier is intact, no problem in the stomach. This more acid will go towards the duodenum, which does not have the barrier and will cause duodenal ulcer. Whether it is gastric or duodenal, patient presents with epigastric pain, where we advise lifestyle modification first, then we give PPIs. If it's a bacterial story, PPI may relieve symptoms to some extent, but not completely. So patient will keep on coming to us again and again, and then we'll have to do upper GI endoscopy. If we take a biopsy from the prepyloric region, we can take the help of GIMSA, thin starry silver stains to identify this bacteria. We can do a rapid urease test on the biopsy specimen, that is CLO test, Campylobacter-like organism test to detect H. pylori. We can do a urea breath test using radio-labeled 13 carbon or 14 carbon, 13 carbon more commonly used, and this can diagnose this Helicobacter pylori. Bacteria is present. To destroy the bacteria, we have to give antibiotics. So we give a triple drug therapy, 2 antibiotics, 1 PPI for 14 days, amoxicillin, clarithromycin, and omeprazole. In quadruple therapy, we add bismuth subcitrate. We can also give sequential therapy. First 5 days different protocol, second 5 days different protocol. Special gastritis. Special gastritis like Menetrier's disease, where there is gross hypertrophy of the gastric mucosal folds. This is pre-malignant. Reflux gastritis. Whenever we are doing gastric surgery, especially when we are chopping off the pyloric sphincter, and suppose we are doing a gastrojejunostomy, the jejunal contents will reflux into the stomach, and this jejunal alkaline contents will cause damage to the stomach mucosa, that is reflux gastritis or alkaline gastritis. And if the story persists, the stomach mucosa would like to become as jejunal mucosa, so there will be intestinal metaplasia in the stomach, which can lead to adenocarcinoma in the stomach. Peptic ulcers. The commonest site of peptic ulcer is first part of duodenum. The second commonest site is the stomach, lesser curvature, prepyloric region. Other sites where we can find these peptic ulcers, which is just the ulceration of the peptic mucosa, is the lower esophagus, stoma of gastrojejunostomy, and Meckel's diverticulum. The commonest reason for peptic ulcer is Helicobacter pylori. However, various S like smoking, spirits, spices, stress, steroids syndrome, Zollinger-Ellison syndrome, or gastrinoma. Peptic ulcer seen in head injury patients are Cushing ulcers. Peptic ulcer in burn patients are curling ulcers. Skin ulcer in burn patients are Marjolins ulcer. If we look at the difference between duodenal and gastric ulcers are much more common. They are commonly seen in young, rich people. They are usually smaller. Gastric ulcers are less common. They are seen in older people, poor people, and they are larger in size. Basic pathogenesis of duodenal ulcer is huge amount of acid coming towards the first part of the duodenum. That means acid secretion will always be high. While in gastric ulcer, it is the disruption of the gastric acid mucus barrier, so that even if there is small amount of acid in the stomach, if the mucus barrier is disrupted, that small amount of acid will come in contact with the stomach mucosa and will damage the stomach mucosa, leading to this gastric ulcer. That means acid secretion can be anything in gastric ulcer. It can be normal, it can even be low. Whether it is gastric or duodenal, both will present as epigastric pain. However, if the patient tells us that this epigastric pain usually occurs 2 to 3 hours after meals and it is relieved by taking food, it is more likely to be duodenal ulcer. But if the patient says the epigastric pain occurs immediately after meals and it is relieved by vomiting, then it is more likely a gastric ulcer. Because food is relieving the pain in duodenal ulcer, so patient keeps on eating after every 3 to 4 hours, the appetite and weight of the patient increases. But in gastric ulcer, patient is having pain after eating and pain is getting relieved by vomiting. So patient develop food fear that if he takes the food will hit the ulcer and he will have pain. So he is afraid of eating, his appetite and weight decreases. O blood group patients have more chances of duodenal ulcer. A blood group patients have more chances of gastric ulcer. How to approach this epigastric pain? First, lifestyle modification. If that does not help, then PPIs. The gold standard treatment for peptic ulcer, PPIs. In gastric ulcer patient, we add sucralfate, which help in forming a coating of the surface of the stomach mucosa, preventing acid in the stomach to come in contact with the gastric mucosa. If this does not help, which is a very rare story, then we actually need to investigate these patients to identify what is the cause of epigastric pain. So we can do upper GI endoscopy, and based on what we find on endoscopy, we proceed accordingly. If we have taken a biopsy from the prepyloric region which demonstrates the H. pylori positive, then we give eradication therapy, the same triple drug therapy for 14 days, 2 antibiotics, 1 PPI, amoxicillin, clarithromycin, and omeprazole. If the symptoms recur again, then we consider reinfection with H. pylori and we give re-eradication therapy. If the patient presents with the symptoms again, then we have tried our level best as far as medicines are concerned. We have given PPIs, we have given eradication therapy 2 times, and still the story is not getting sorted. Then we have to do surgery. When we have to do surgery for duodenal ulcer, because the game in duodenal ulcer is high acid, so our surgery will aim in reducing the acid secretion. Like if we chop the vagus nerve, then the parietal cell stimulation will decrease and the acid secretion will also decrease. So we have got different types of vagotomy: truncal, selective, and highly selective. The surgical treatment of choice for duodenal ulcer is highly selective vagotomy or parietal cell vagotomy, where we denervate only those nerve fibers which are supplying the parietal cells. So we preserve the motor fibers, nerves of Letaget, so the motility of the stomach remains intact and no drainage operation is required. In selective and truncal vagotomies, because the motor fibers are also getting damaged, which reduce the motility of the stomach, so we have to do a drainage operation, either pyloroplasty or gastrojejunostomy. Truncal vagotomy will have the best control in acid secretion out of these three vagotomies: truncal, selective, and highly selective. So the chances of recurrence of duodenal ulcer will be least in truncal vagotomy out of these three vagotomies. Highly selective vagotomy will have maximum chances of recurrence of duodenal ulcer out of these three vagotomies. When we have to do surgical treatment for gastric ulcer, because gastric ulcer should be considered as malignant unless proven otherwise, so it is better to remove that portion of the stomach which is having the ulcer. So generally the ulcer is on the lesser curvature prepyloric, so we have to remove the distal portion of the stomach. The surgical treatment of choice for gastric ulcer is Roux-en-Y gastrojejunostomy, which is a modification of Billroth 2, wherein to prevent bile pancreatic juice reflux from the jejunum into the stomach, instead of making a loop gastrojejunostomy, we make a Roux-en-Y gastrojejunostomy. Billroth 1 is gastroduodenostomy, Billroth 2 is simple loop gastrojejunostomy. There can be complications of these peptic ulcer surgeries. There can be duodenal stump blowout which occurs on 4th post-operative day. There can be dumping syndrome, which is a post-cybal syndrome, which can be early dumping or late dumping. When we have removed the distal portion of the stomach, when the pylorus has been removed, when the stomach has been connected directly to the jejunum without a sphincter in between, then what can happen? When the patient takes the meal, the food will not stay inside the stomach. It will be dumped into the jejunum. And within 5 to 10 minutes after meals, the jejunum will send signals to the entire body to send blood and fluid towards the intestine, which will cause bloating sensation, epigastric pain, abdominal cramps, nausea, vomiting, diarrhea type of features. And because the fluid has migrated from the peripheries, the patient would be in tachycardia type of features, cold peripheries like that. This is because of high osmotic load in the intestine, early dumping. This early dumping can last maybe for half an hour, 1 hour or 2 hours. Late dumping, this occurs in the second hour after meals. In the second hour, because of sudden absorption of glucose into the blood, there may be sudden high glucose in the blood which can stimulate the pancreas to produce huge amount of insulin. Excess insulin produced by the pancreas can lead to reactive hypoglycemia, hypoglycemic symptoms, faintness and tremors in the second hour after meals. And these hypoglycemic symptoms have to be resolved by giving more food. So this can become a vicious cycle. What we need to do is to tell these patients that please do not take a bulky meal. You do not have the pylorus. So whatever you are eating, that will not stay in the stomach. That will be dumped into the jejunum, and then jejunum will not be able to handle a bulky meal inside. And you will experience these early and late dumping symptoms. So it is better, instead of taking bulky meal, you take small, frequent meals. Small meals will not cause that bulk in the jejunum and will not cause those dumping symptoms. These dumping symptoms are more pronounced if the patient is taking glucose-rich foods, juices. Other complications of peptic ulcer surgery can be post-vagotomy diarrhea. The reason is not well understood. Nutritional deficiencies like iron deficiency, vitamin B12 deficiency, calcium, phosphorus, protein deficiencies can occur. Iron B12 deficiencies will require injectable supplementations. High risk of gallbladder stone formation after peptic ulcer surgeries, because if you are chopping the motor vagal fibers which were going to the gallbladder, the motility of the gallbladder will decrease. Stasis of bile in the gallbladder, infection, stones inside the gallbladder. Gastric cancer can occur in the residual stomach after gastric surgeries because of jejunal alkaline reflux into the stomach, causing alkaline reflux gastritis, intestinal metaplasia, and cancer. There can be complications of peptic ulcer like they can bleed, they can perforate, Bleeding is more commonly seen from the ulcers which are situated on the posterior surface of first part of duodenum where there is gastroduodenal artery. Gastric ulcer bleeding is rare. If it occurs, it often occurs from left gastric artery. Perforation, ulcers which are situated on the anterior surface can perforate, and this will cause leakage of gastric duodenal contents in the peritoneal cavity, causing peritonitis. Patient present with diffuse abdominal pain, anorexia, nausea, vomiting type of features, and maybe shock-like features. If the patient comes in emergency with shock, because this might be peritonitis, septicemia, septic shock type of story, because the vital organs may not be receiving sufficient oxygen. So first, to save the life of the patient, you have to supply oxygen to the vital organs. So you give IV fluids and IV antibiotics. Try to make the patient stable. Once the patient is stabilized and you are doing the clinical examination, because it is peritonitis, the entire abdominal cavity, so there will be diffuse tenderness all over the abdomen, and the muscles of the anterior abdominal wall will resist any external pressure, so there will be diffuse guarding and cardboard-like rigidity on the abdominal wall. If you are suspecting perforation and the patient has been stabilized, then you do a X-ray. If patient can stand, take a chest X-ray in standing position, including both the domes of diaphragm. If it is a gastric or duodenal ulcer perforation, or maybe a jejunal, ileal or colonic perforation, because we know the entire GIT is a hollow viscous having air. So, gastric, duodenal, jejunal, ileal, colonic. The gas will leak into the peritoneal cavity. Free air in the peritoneal cavity is pneumoperitoneum, and gas always rises up. So when you are taking an X-ray in a standing position, this gas will rise up and come to lie beneath the domes of the diaphragm. And we prefer seeing it below the right dome of the diaphragm. Not on the left side, because we can get confused with a normal stomach gas shadow on the left side due to fundus of the stomach. If the patient cannot stand, then we prefer taking X-ray in supine position where we can see gas below the midline, or we can take the X-ray in a lateral decubitus position, the left lateral decubitus position, so that the gas rises towards the right side and we see below the right dome of the diaphragm. This X-ray will only give us about the gas under diaphragm, which can be because of gastric, duodenal, jejunal, ileal, colonic perforation. If the patient is stable and we still want to confirm that what is the site of perforation, then we can do a CT scan. And remember, because we are talking about perforation, we will not use barium. Because we are giving IV fluids, IV antibiotics, and it's a case of peritonitis, maybe septicemia, the IV antibiotic which we are giving, that dose may not be sufficient to control such a big bacterial party in the peritoneal cavity. So we should do a laparotomy, do a nice peritoneal lavage, 10, 20, 30 liter of normal saline. This peritoneal lavage will be life-saving for this patient. And then decision whether to close or not to close the perforation depends on the amount of contamination. If the patient presented to us early, within 24 to 48 hours, the contamination may be less and we can close the perforation, where we can use the omental patch, Gram's patch to close the perforation. However, if the patient presented to us late, after 24 to 48 hours, where there would be cross contamination, then we just leave the drains in the peritoneal cavity. If we look at the different bezoars, trichobezor, phytobezor, lactatobezor, tricho is hairs. Hairs inside the stomach is trichobezor, seen in young psychiatric females. They keep on plucking their hairs, swallow their hairs, and this can cause gastric outlet obstruction. And the surgeons have to do a gastrotomy to take this trichobezor out, and then refer this patient to a psychiatrist for treating the primary problem. Phytobezor is vegetable matter inside the stomach. Lactatobezor is milk products inside the stomach. This phytolactatobasor is seen whenever the gastric motility reduces. Like in prolonged immobilization, the motility in various areas of the body, all the peristaltic movement slows down, the speed of blood also slows down. Or if a patient has undergone previous gastric surgery, maybe due to vagal motor fiber denervation, the motility of the stomach goes down, which can lead to phytobasor and lactatobasor. Bariatric surgery, this is surgery for morbid obesity. It's a metabolic surgery and not a cosmetic surgery. Indication for doing a bariatric surgery: if the BMI is more than 40 or if the BMI is more than 35 associated with comorbidities like diabetes mellitus, hypertension, osteoarthritis, sleep apnea syndrome, coronary artery disease, cerebrovascular accidents, then we do this bariatric surgery. Out of various bariatric surgeries available, the most effective would be Roux-en-Y gastric bypass, but the preferred and most commonly performed is a sleeve gastrectomy. We can do a vertical banded gastroplasty or an adjustable bariatric surgery is LAGB, that is laparoscopic adjustable gastric banding. Right. Thank you very much for your patience, guys. Thank you very much for being so lovely. God bless you abundantly. And remember, my dear doctors, you have done great work in the last 5-6 years. Do not underestimate your power. You have got everything inside you. The fire in your belly should be burning all the time. Play with a cool mind. Play with a patient mind. Be smart. You know you can do it. You have to follow a strict study plan. These small baby steps taken today are going to give you big fruits later. Do not get disheartened at any point of time. Do not lose hope at any point of time. Even if you are feeling exhausted or even if you are feeling low at any point of time, just try to pinch yourself. Just try to imagine your parents' eyes, because you all know that it is not only your sacrifices which are at stake now, but it is your parents' sacrifices also which have to be rewarded. And God has made you the vehicle to realize your parents' dreams, to realize your parents' sacrifices. So let nobody on this earth come in between your parents' dreams. Fight it out as hard as possible, because you can do it and you are going to do it. Nobody can stop you. अपनी हिम्मत नहीं हारना बेटा, अपने जज्बे को, अपने हौसले को बुलंद रखना है। खुद को कर बुलंद इतना कि तकदीर बनाने से पहले खुदा बंदे से खुद पूछे, बता तेरी रजा क्या है। यूं ही आप डॉक्टर्स की जय जयकार नहीं होती, कोशिश करने वालों की कभी हार नहीं होती। कोशिश करने वालों की कभी हार नहीं होती। बस हिम्मत रखिएगा, हौसला रखिएगा, और किसी भी समय अगर आपकी हिम्मत टूटने लगे तो सिर्फ अपने माँ बाप की उन आंखों को याद करिएगा। बहुत सारे ऐसे दिन भी गए होंगे पिछले 6 साल में, माना कि आपने पिछले 6 साल में 24 घंटे में सिर्फ एक बार खाना खाया, लेकिन बेटा शायद कुछ रातें ऐसी भी गई होंगी जब आपकी माँ ने सिर्फ पानी पी के अपना पेट भरा होगा, सिर्फ इसलिए कि आप ठीक से खा सकें, आप ठीक से पढ़ सकें। उस माँ के सेक्रीफाइस को किसी भी कीमत पे किसी को भी तोड़ने मत देना। बस God bless you. Wish you all the best. We are done for today. God bless you. See you.